Recording in
Speakers,
progress.
Pascal Boileau from France. He will speak about the intermedullary nailing for this type of fractures. Ines Brai from Latvia. He will speak about Phyllis plate. Zenon Kokalis for Patras University for the conservative treatment of these fractures, and me, the use of the reverse shoulder arthroplasty in elderly patients with proximal humeral fractures. Also, I just want to talk about the participants competition, the 2016 Best Participants Competition. This is an engaging challenge for the circuit members that rewards active participation in our educational activities. So you can earn points by attending these webinars and answering the questions at the end of each presentation. And the winner will be announced in June 2026, and he will receive a free registration for the SICKET Congress in Barcelona. So now I will invite Zenon Kokalis, a professor of orthopedics in my hospital, Patras University, to talk about the conservative treatment of proximal humeral fractures. Okay, Zenon.
Good evening to everyone. I want to thank SEKEK and Professor Panagopoulos for including me in this nice panel. And let's open with my talk. My talk is conservative treatment of proximal humeral fractures. What are the boundaries? I have nothing to disclosure. Okay, let's start with a couple of cases. Males, 74-year-old, right hand dominant. He sustained this 4-part fracture with graded tuberosity displacement, as you see in these X-rays, in internal rotation, external rotation. This fracture is 3 months after injury. It was nicely healed without surgery, and this is the clinical result. The patient was very satisfied. Almost a full range of motion, full forward flexion, external rotation, and he had nothing significant problem. Another case, female, 47-year-old, he had these 4-part fractures. As you see, it looks undisplaced on her left shoulder. This is her X-rays 1 month after the injury. She was treated without surgery. As you see, there is a line there. And she presented to my office 4 months after injury. The fracture was healed very well, but she wasn't satisfied with this result. Especially, she had limited external rotation. So we know proximal humerus fractures are very common. There is an increased annual incidence, 30% every year. Treatment options include conservative treatment, open reduction and internal fixation, nailing, hemiarthroplasty, and RSA. From this classical paper, Management of Proximal Humerus on 2009, there was no agreement between surgeons. Let's see this paper from the Australian registry that is an analysis of almost 78,000 cases from 2008 to 2017, and we see that there was a decrease in operative management for 32% in 2008 to 22% in 2007. ORIF was decreased significantly, hemiarthroplasty also, and RSA use was increased significantly from 4.1% to 24.5%. From the literature, we know that conservative management leads to satisfactory result in most proximal humerus fractures, especially in the elderly. The primary goal is to achieve a functional, painless shoulder through early mobilization followed by rehabilitation, relying on the fact that the proximal humerus fracture has excellent remodeling capabilities. The boundaries of non-operative management are defined by fracture characteristics and patient-related factors. Main contraindications to conservative management include head splitting fracture or those with more than 40% articular surface involvement, typically that requires surgery. Displaced fracture dislocation that cannot be reduced closely, such as is in this case, and usually they need open reduction and internal fixation or RSA in some cases. A graded tuberosity displacement of more than 5 mm is a common threshold for surgical reduction due to the risk of subacromial impingement and loss of abduction and external rotation. And here I present the case, a female, 49-year-old male. She had this anterior fracture dislocation with graded tuberosity superior displaced. This patient didn't have any surgery. She presented to my office 4 months after the injury, and she had this result. Of course, open fractures need immediate surgery. And when the humerus shaft is severely displaced, 33% to 100% translation, and lacks contact with the head, there is a high risk of non-union. And this case needed an ORIF. Relative contraindication for surgery. Conservative management is generally indicated for minimal displaced fractures, often defined by the NIR criteria, such as in this case, fracture with displacement of more than 1 centimeter or angulation of more than 45 degrees are considered for surgery, especially in younger or active patients. But the stability of the fracture is more crucial than the number of the parts. Impacted two-part fractures or valgus impacted four-part fractures are often safely treated without surgery, even in older patients, due to their inherent stability. Here is a case, female 65-year-old, left shoulder, valgus impactus fracture that was treated without surgery. This is the X-ray 3 months after the injury, and this patient treated conservatively, and she had an excellent result. However, marked valgus displacement leads to a higher chance of disruption of the vascularity of the humeral head and a higher risk of a vascular necrosis. Here I present the case, female 68-year-old. She had this right shoulder valgus impacted fracture with graded tuberosity displacement around 5 mm. This is her X-rays 3 months after the injury, and this patient developed an AVN, and I had to do an RSA in order to improve her function and pain. Valgus posteromedial fractures are characterized by comminution of the posteromedial neck-head junction. They might be stable or unstable. These fractures considered stable when the humeral shaft is impacted into the humeral head and there is no major displacement on the lateral side. Here I present the case, male, 21-year-old. He had this left shoulder valgus posteromedial fracture. This is his X-ray 3 months after the injury. Although the head is in valve position, this patient had a satisfactory result with okay external rotation. Valgus posteromedial fractures, they might be unstable if there is a severe comminution or loss of the medial cortical pillar. The fracture is considered unstable and that this case needs surgery. Patient factors, while non-operative treatment is preferred for the elderly, younger active patients with displaced fractures may require surgery to restore full function. Significant medical conditions preventing surgery may force conservative management even if the fracture pattern is unstable. Severe osteoporosis might take rigid fixation difficult, sometimes forcing a conservative approach even the functional results are not very good. Management boundaries during conservative treatment. To prevent failure of conservative treatment, strict monitoring is required as secondary displacement can occur. So weekly X-rays are required for the first 3 weeks to ensure the fracture does not displace, particularly in the first 10 to 14 days. This is a case, 64-year-old female. She had this 3-part varus posteromedial fracture. This is her X-rays at the initial presentation. That fracture looked quite stable, but 2 weeks after the injury, she had this varus position of the head, and this patient had an open reduction and entire fixation. Conventional treatment involves 3 to 4 weeks of mobilization and sling, but current evidence suggests early mobilization as early as 1 to 2 weeks for reducing stiffness. Exercises are initiated as soon as the pain allows. Cotman pendulous exercises can be performed from the beginning, and passive forward elevation exercises in the supine position can be started from the 3rd to 4th week. What to expect? According to this 5-year follow-up PROFER trial comparing operative and non-operative treatment of adults with displaced fracture of the proximal humerus, there were no statistically or clinically significant difference between operative and non-operative treatment at each follow-up point. Another systematic review meta-analysis of 7 RCTs and 15 observational studies. There were 910 patients treated operatively and 833 non-operatively. There was no difference in function, and these authors recommend non-operative treatment for the average elderly patient aged more than 65 with a displaced proximal humerus fracture. Christian Spross suggested an evidence-based algorithm to treat patients with proximal humerus fractures based on the deltoid tuberosity index. DTI less than 1.4 correlate with low bone mineral density of the humeral head. These authors suggested this algorithm based on DTI and patient-related factors. In this study, 97% of cases had satisfactory results. However, we should note that only 1 patient had a 3-part fracture. 3 patients needed surgery due to secondary displacement. However, more complex or displaced fractures are associated with worse outcomes after conservative treatment. In this case, in this study from Torrance Carroll of 70 proximal humeral fractures, 4-part fractures obtained the worst functional outcomes, followed by the 3-part fractures and 2-part fractures. To conclude, conservative treatment is the gold standard for the majority of cases, 80 to 85% of proximal humerus fractures, particularly in the elderly. Closed follow-up of the patient is needed at the first 3 weeks, followed by early mobilization and proper rehabilitation. Surgery should be considered in fracture where the humeral head is severely compromised, when there is gross instability between the humeral shaft and the humeral head, and in those cases which displacement of the tuberosities will lead to symptomatic malunion. Thank you.
Thank you very much, Simon, for this excellent presentation. Now we can have the question for the competition.
So the question from this talk is the following. A 55-year-old active physical therapist sustains a fall and is diagnosed with a proximal humerus fracture. According to the standard knee classification and clinical guidelines, which of the following findings would be most likely represent a boundary where conservative treatment should be abandoned in favor of surgical intervention? First, a non-displaced surgical neck fracture with 5 degrees of varus angulation. Second, an isolated graded tuberosity fracture displaced superiorly by 6 mm. A 2-part surgical neck fracture with 5 mm of translation. And a fracture where the patient can begin passive pendulum exercises within 7 days. So you can vote for the correct answer.
And we can have the answer now. Gina?
Yes, the right answer is B, an isolated graded tuberosity fracture displaced and superior by 6 mm. as I mentioned in my talk, greater tuberosity displays more than 5 millimeters, especially if the tuberosity goes superiorly. It's an indication for surgery. Especially in young and active patients, some surgeons suggest these displacements should be no more than 3 millimeters.
Okay, thank you very much. Now we go with Professor Pascal Boileau from France. So his talk is about intermedullary nailing proximal humeral fractures. Please, Pascal.
Hello, I'm trying to share my Sorry, I have problem to share, partager.
Zenon, have you stopped your sharing?
I think yes. On the top, Pascal, you should share screen.
Pascal, at the bottom, you can see the share, the green arrow.
Yeah,
So you
I'm
put that, you upload your presentation.
I'm sorry, there is a problem here. I don't know why.
Pascal, c'est Marie de la CSEC. Est-ce
Ouais.
que je peux vous aider à distance?
Oui, bien sûr, parce que là, je sais pas, je veux partager, j'arrive pas.
Alors, quand vous appuyez sur partager la flèche verte, normalement, il vous propose un certain nombre de fenêtres. Est-ce que votre
Ouais.
présentation est ouverte dans PowerPoint?
Ouais, mais il n'y a aucune des trucs, des fenêtres qui ouvrent sur une.
Est-ce que vous arriveriez à fermer les fenêtres dont vous n'avez pas besoin pour la présentation?
Ouais, peut-être faites passer le speaker suivant et je vais essayer d'arranger les choses.
Okay. Okay. Maybe Ines, if you are ready to present your presentation, in the meantime, Pascal will find a solution for his presentation.
Right from Latvia, so he's a very famous shoulder and hand surgeon. So he's about to present the tips and tricks for a successful fixation of a proximal humeral fracture with a Phillips plate. Okay, Ines.
Hey, thanks. So yes, we will speak about the proximal humerus fixation with a locking plate. So as it was mentioned, my name is Inese Brede. I'm orthopedic surgeon from Riga, Latvia, and these are my positions, and I have nothing to disclose regarding this topic. So today I will discuss how to achieve anatomical reduction, stable fixation, and preservation of blood supply with locking plate for the proximal humerus fracture, and also how to avoid complications. And actually, we can jump straight into the case. This is the X-ray of one of my patients that I treated. He is a 63-year-old male. He is healthy. He sustained fall from roof. It was isolated trauma, and he is a farm owner. And from the CT scan, actually, you can see that it's quite a nasty 4-part proximal humerus fracture. And I have a couple of options how to treat him. And as I think he's still not so old and he needs to lift heavy objects, so for me, the first choice was open reduction and internal fixation. So as Zenon already told us about the conservative treatment and the literature, I would say the literature is a little bit controversial. So we know that most of these fractures we need to treat conservatively. And also, if you look at this Profer study that was mentioned, that the conclusion was that most of these patients you don't need to treat surgically. But I'm afraid actually that this patient definitely will not benefit from the conservative treatment. So for me, how I think about these fractures is primum non nocere, or can I make this fracture better? And yes, definitely for this patient, I can make this fracture better. And I can make direct visualization of the fragments. I can do the reposition. I can gain bony stability, and there will be no additional damage to the rotator cuff. Sure, I know that there will be some deltoid to plate scarring, and there is a risk of failure and avascular necrosis. And actually, if we look at the literature, the complications after the proximal humerus plating is quite alarming, and the number can be up to 37%. That actually means that this procedure is quite demanding, and it requires quite good technical skills from the surgeon and also a good setup. And that's why in this presentation, I would like to guide you through some steps, how I do this, and share some tips and tricks. So for position, I usually use a beach chair, but you can also use supine position. And then I think it's really important to position your C-arm correctly. So either you can do it from the side or from the top. And for this patient, I decided to go from the top. And this is a coronal view that you can see. And this is the axial view that you can see. Quite bad, right? And then, of course, I proceed with the approach. For me, the one that I always choose is deltopectoral because it's anatomical neurovascular interval. In this case, I can preserve the muscle mass and the axillary nerve, and it's easier for the revision because I will be the one who will do afterwards the replacement if it will be needed. And also, if there's any doubts that there can be some plexus or axillary artery injury, it's the place where you can easily access them. Sure, you can also use anterolateral approach, but then you need to take into account that there is risk to the axillary nerve. You can damage the deltoid muscle, but it will be easier for you to reduce the greater tuberosity. And then once I'm here, the first step that I do, I always use the rotator cuff hole sutures in order to manipulate my tuberosities. And then I switch the C-arm to the coronal plane. And here I want to reduce the medial hinge of the proximal humerus. I want to restore the varus and valgus. And also I want to restore neck shaft angle. And for that, I can use the key wires, the cuff sutures, the forceps, like here in our case. And also I can do it plate assisted, but be aware you can get the cutout from the screws. So what I want to achieve, I want to achieve my neck shaft angle around 130 and also humeral head height 5 to 8 millimeters. And then I switch my C-arm to the sagittal view, and here I want to restore retroversion. And you need to remember that naturally there is 17 to 35 degrees of retroversion. And I really don't want to have any apex anteriorly. As I said, I want to have my retroversion on the opposite, and I want to restore any translation that is here. And for that, I can use the arm positioner, also resident. I can use the hook or spike pusher key wires and also the cuff sutures. And you can see here that the retroversion is nicely restored. And afterwards, I want to somehow hold my position, and for that I can use 2.0 key wires from anterior shaft to posterior head, and I want to beat them out of the way where my plate will be. And then it should look a little bit like light bulb. And afterwards, I switch to the tuberosities. And here I can use for my fixation, in most cases, sutures. They are enough, but I can add also screws and also some small plates. And Why it is important? Because your reduction quality correlates to avascular necrosis afterwards. And this is really nice study from excellent surgeon Martin Klaub. And he showed that if your reduction is anatomical, you can reduce the risk to the 2%. But if your reduction is poor, then avascular necrosis risk is really high and can go up to 60%. And not only your reduction, but also initial displacement is really important. And here, in this case, it's 77-year-old female. And you can see that here are, I would say, all of Hertel's criteria. There is angular displacement of the head more than 45 degrees. There is no integrity of the medial hinge. The length of metaphyseal head extension is really short. There is really big displacement of tuberosities. And there, I would say there is almost dislocation. Maybe head split is not here. And sure, when I did my approach, I can take out actually the head with the forceps without any additional release. And you can imagine there will be no blood supply. So there's no way you can achieve any good result afterwards. And that's why you need to proceed with replacement in these cases. So you need to remember that the most important blood supply comes from posterior circumflex humeral artery, and it's really important to be gentle and to preserve this periosteal sleeve around the humors. And this fracture perfusion depends on the bony stability. And I would say the most important, and this is what you really, really need to remember, is the medial support, because if you will not restore it, it will lead to the reduction loss. And there are a couple of ways how you can do it. You can do the reduction of the medial cortex. Then sometimes you can do the shaft medialization with impacted head. And of course, option is locking screws inframedial or so-called Kalkar screws. Look what happens if you don't do it. This is quite, I would say, easy fracture. And if you do the fixation like that, look, 1 month after, there's varus displacement, and 1 month more, there is really significant displacement afterwards. So reduction is really important because it changes rotator cuff tension, and that leads to decreased function, range of motion, strength, and increased pain. And varus and antecurvatum is the worst that you can leave. And then once you have your position, then it's really important to have a good position of the plate. It should be 5 to 8 millimeters distal to the top of greater tuberosity, of course, along the axis of the humeral shaft, 2 to 4 millimeters posterior to the bicipital groove, and take your screws 4 millimeters shorter than you measured. And when you drill, don't drill through the articular surface. Otherwise, there will be nothing that can stop the screws from migrating into the joint. And this is a nice study. They took 100 cadaveric bones and put the plate on them. And they actually saw that there is really a big mismatch to the plate and the humors. So be aware, don't adjust the humors to the plate. There can be mismatch. And then afterwards, if you see that there's some bone loss, you can use the bone substitutes, either the cement. You can also do the shortening. You can use the iliac crest and also allografts, either the fibular strut or femoral head. So my receipt for the proximal humerus fixation would be to start with rotator cuff hole sutures, then you align head to the medial shaft, correct any varus and valgus, switch to the sagittal plane alignment, use the key wires from anterior shaft to posterior head, then reduce the tuberosities, use any augmentation if needed, and then fix with the plate. So what is acceptable reduction? The next shaft angle should be around 130, humeral head height around 5 millimeters. The screw tips should be 10 to 15 millimeters from the articular surface. There should be medial support and there should be calcar screws. So this is our farm owner with a really bad fracture. So I think I succeeded with my reposition. So for the take-home message, individualize your approach. Take into consideration the factors from the patient, fracture, your abilities, and technical backup. Restore anatomy. It is really essential. Preserve lateral periosteal sleeve. Be gentle. And valgus is better than varus if you need to choose. Thank you.
Thank you very much, Ines, for this excellent presentation. Now we can have the question for the competition. Also, the panelists can ask questions in the question and answer box. So we will discuss later. Okay, Ines?
Yeah, so now we have the question. So what is the most important goal while you fix the proximal humerus fracture with locking plate? Either it is achieve anatomical reduction that looks beautiful on X-ray and Instagram. Either it's restore medial calcar support to prevent varus collapse. Either it is finishing before the scrub nurse starts judging you, or make sure the plate is perfectly centered for the post-operative CT scan.
Now you can answer and wait for 10 seconds. Okay, Ines, what is the correct answer?
Sure, I never want to be judged by scrub nurse, but the restoring medial calcar is the most important one.
Okay. So thank you very much. Pascal, are you ready?
I hope so. I'm not sure.
Je ne peux pas charger votre présentation, donc j'espère pouvoir le faire à l'issue de la dernière présentation.
Ok, alors je
Ah,
pense qu'il faut que je rallume Zoom depuis le début, non? Attendez, je vais essayer de partager. Je comprends pas pourquoi ça fait ça. D'habitude, ça marche tout le temps. Quels que soient les écrans que je mette, il n'y a rien. Bon, faites passer l'autre speaker, je suis désolé, et je vais rallumer Zoom depuis le début.
très bien, moi aussi
Je
j'essaie
vous ai
d'importer
envoyé ma
parce que-
communication par mail.
Oui, oui, j'arrive pas à la charger,
Vous
ça
pouvez
ne
pas.
fonctionne pas encore. Je vais continuer à essayer.
Attendez,
je vais demander-
attendez. Peut-être qu'il y a quelque chose qui se passe là. Il y a quelque chose qui se passe, mais non.
We're trying to find Pascal's presentation. Maybe Andreas, if you can present your topic. In the meantime, we will find a way to show Pascal's presentation.
My presentation is
D'habitude, ça
about
marche.
the reverse shoulder arthroplasty for the elderly patient. So we know that we have an increased overall incidence of proximal humeral fractures, and the overall incidence is also very high. Also, we have increased age of presentation. Most of these patients is about 75 years old. And about the decision of how to fix these fractures, we have all these different things to think: the fracture type, the bone quality, the integrity of the medial calcar, the tuberosity comminution, the risk of vascular necrosis, the congruity of the joint, and of course the patient age and the functional demands. And these are our options: conservative treatment, as Zenon said before, fixation either with a nail or a plate, and of course hemiarthroplasty and reverse arthroplasty. So we have all these boundaries about the conservative treatment, and these are cases from our hospital with a conservative treatment initially. You can see that the result is not good. But in cases like that, this lady is 86-year-old and 3 months post-injury after a conservative treatment for a good fracture, not very displaced. You can see that the result is excellent. Or this lady, 84 years old, 9 weeks post-injury with a fracture dislocation and graded tuberosity fracture, as you can see. The result is quite acceptable. But sometimes, the the operation that we choose is very, very bad. And of course, we have the fillers plate in 2003 that solve most of our problems because it's a friendly implant with good results. And you can see that after the initiation of the fillers plate, the open reduction and dental fixation of this type of fractures rise from 40% to 62%. On the other hand, after the introduction of the RSA for the fractures of the humerus, from almost 9%, we went up to 44% after the release of the fracture stem. But still, we have about 70% unanimous agreement of either operative or non-operative treatment. This is a case, 70-year-old, 1 year post-operative. The Coston score is 87, so we can say that this is a good outcome. But still, we have a lot of complications in this type of fixation. Varus malunion, avascular necrosis, screw perforation, and this is an old study from 2011. So you see all these complications, and in order to avoid them, you should deplate in a good profile, a little bit lower, calca screws, short screws, and even if you do all these things that Inez said before, still we have complications. This is a more recent study in 2022. So it's a systematic review and meta-analysis of 76 studies, more than 4,000 patients, and the complication rate still it's 23%. Screw cutout of vascular necrosis, and if you see patients over 55 years, the complication rate was 30%. And the overall reintervention rate was about 10% and 20% for the older patients. And this is a nice study, very recent, for the use of the fillers plate in proximal humeral fractures in the elderly. You can see all these type of complications. And also the methodological quality of all these studies was predominantly critical low in this study, that was not possible to evaluate the association between the quality and the conclusions. And then we have the PROFER study in 2015, comparing non-operative treatment with ORIF. There was no difference in the scores, in the complications, in the secondary surgery, but they had only 4% of patients with a near 4-part fracture. This is one of my cases. I want to share that. It's a 69-year-old lady. So I did in this fracture an ORIF with a fillers plate, but she had a pain and decrease ROM at 12 months. And this was the X-ray, as you can see. So I removed the plate. I did an open superior capsular reconstruction with an allograft, a dermal allograft. And one screw stayed here. It was impossible to remove that. But still, the patient had a very, very bad outcome, as you can see. This is the tissue, the supraspinatus with the dermal allograft, very thick, but she has arthritis now, and of course, she ends up with a reverse, with a very low Coston score, 26 months after the initial surgery. So what about the hemianthroplasty? This is a good option when we have these non-reconstructed fractures, split head fracture with metaphyseal extension. I think it's a good choice in younger patients. This is a 52-year-old patient with a good outcome. And also this has been supported from the literature. This is a new study from 2023. So they had 75 patients with acute fracture treated with hemianthroplasty. The mean age was 58 years, young patients, and the mean follow-up was 14 years. And they found that the 10-year prosthetic survival rate was 96%, very good. And the Coston score also in the ASA score was good. Of course, about 20% of the patients had tuberosity complications. We know from the study from Pascal this problem with tuberosity healing and why we have these very, very bad results of hemianthroplasty in the elderly. These are cases when I was resident 25 years ago, so you can see very, very bad outcome. And also, from this paper, we can see that we will have a massive rise in fracture-related procedures after the revision of shoulder arthroplasty. We know why the reverse shoulder arthroplasty is good and have good results, because you can have a very good motion in the absence of a functional rotator cuff. So you don't care about the tuberosities or the integrity of the cuff. You know that you will have a good range of motion even if you don't fix the tuberosities. Of course, this is not true, and I will show you later. So we have an increasing rate of shoulder arthroplasty for the geriatric proximal humeral fractures. This is a study from 2010 to 2029, and you can see this increase. About 59% of rib fractures went up to 30%, and also the proportion of arthroplasty was from 9% to 67%. And compared to ORIF, the arthroplasty was associated with higher cost, decreasing length of stay, and lower mortality and complication rates. Is cost effective? Yes. According to this study from USA, yes, an RSA has 60% probability of being the most cost-effective treatment option. What about the comparison between the RSA and the ORIF? This is a multi-center randomized control trial, the Delphi trial. So they compare reverse arthroplasty with ORIF for displaced proximal humeral fractures in the elderly, so between 65 and 85 years old, 124 patients. The Coston score was about 10 points more than the ORIF group, and also they have very good results, patients between 65 and 74 years old with type C2 fractures, very bad fractures, 4-part fractures. Another study, this is a propensity mass analysis of more than 5,000 patients, elderly patients, mean age about 71. So patients treated with ORIF were more likely to have a reoperation or hospital admission than patients who underwent RSA at both 1 and 2 year follow-up. And for the ORIF patients with 4-part fractures and osteoporosis, you can see the percentage of 40% and 20% increased risk of reoperation. This is an example for my patients. This is an acute RSA in a 76-year-old female. The Costa score was quite good at 12 months. Another case, and you have considered that, is a fracture like this in a patient with rheumatoid arthritis. You can see the other shoulder has osteoarthritis. This is a split head fracture, so it's an absolute indication to do an RSA. Another example is the fracture dislocation. This is a 76-year-old female that during the operation there was no supraspinatus and no infraspinatus. So if you do a hemiarthroplasty, it will fail. So the option is reverse shoulder arthroplasty again. How can we prove the results of the RSA? This is a very important study. It's a systematic review and meta-analysis, and they found that the rate of non-healing of the great tuberosity was about 31%. So if you do in an RSA, in an acute fracture, an anatomic great tuberosity reduction, this provides improved range of motion, better anterior elevation, abduction, and external rotation. And also, the question, do we have to use cement in elderly patients? In this study, you can see that there is no difference if you use cement or not. What about the comparison between the reverse shoulder arthroplasty and hemiarthroplasty? Okay, the studies say that the reverse arthroplasty is better. The Coston score was at 2 months was better in the RSA group, and the same results at 24 months. And in this study, with 100 patients, you see this Coston score in the RSA group and this score in the hemiarthroplasty. So they had also greater mean satisfaction. What about the comparison of the RSA with conservative treatment? So this is a randomized control trial, and in 1 year follow-up, the RSA group had better functional outcomes than the non-operative treatment. You see the Costa score 61, and the other 50 to 10 points more, with a mean difference of about 9 points. So here we have the PROFER number 2 study, and now this is the protocol of the study. So now they have adults more than 65 with 3 OPAR fractures. Remember that in the first PROFER study, it was only non-displaced fractures, no 4-part fractures. But in this study, they have to compare RSA, hemiarthroplasty, and non-operative treatment in this population, more than 65. And these are all the outcomes, the Oxford score at 24 months, and also some secondary outcomes. So we expect the results of this study. Now, if you are to do an RSA, it's better to do it early. In this study, it's a meta-analysis and systematic review of 16 retrospective studies with patients more than 65 years old, and they found that the scores were better in the acute RSA cohort. And also, they had a greater shoulder range of motion in terms of forward elevation, external rotation, and abduction. This is an article for our clinic, reverse shoulder laphaloplasty for failed operative treatment of proximal humeral fractures. The main author was called Zenon, and the results, of course, were not so good as in acute RSA. So, to answer the question, should the acute reverse shoulder laphaloplasty be the first choice for acute proximal humeral fractures in the elderly? Yes. Absolute indication is the non-reconstructable proximal humeral fractures, the fracture dislocation, and the split cage fracture, together with all these other indications of RSA. The evolution of reverse total shoulder arthroplasty is that over hemiarthroplasty and ORIF is that provides good pain relief and a reliable and reproducible improvement in functional outcomes. So we have this algorithm. From one side is patient factors, fracture personality, and surgical factors. And then we have the options. So if we have, the non-operative treatment, the majority, 80% of the patients had to be conservatively, regardless of age, with a minimal displaced fracture and regardless of the surgical expertise. The relative indication is this, the benign fracture configuration or an inexperienced surgeon. The relative indications for operative treatment is the young active patient with a more severe fracture configuration and with an experienced surgeon, and the absolute indications for surgery are rare, and it's these 3 or 4 fracture dislocations, head splitting fractures, pathological fractures, open fractures, and neurovascular injury. In my opinion, for this, if you have an elderly, an old patient, it's better to do an RSA than ORIF. And finally, this is my final slide. It's a nice paper from Yaz and Lopez. It's a score that we can use to decide if we go for operative or conservative treatment. So there are 4 different questions: the clinical evaluation, the functional evaluation, the mental evaluation, and the social evaluation. So it's important if the patient has someone to support him. So if the score is less than 3, then we go for surgery. If it is 3 or 4, we have to consider other factors. And if it's more than 4, then we go for conservative treatment. So thank you very much. This is some pictures from our carnival. It's next week. We are famous for this carnival in Patras, and this is our bridge. So thank you very much. We can have the question now for the audience. So a 73-year-old lady sustained a 3-part fracture dislocation of her left shoulder after a steepened fall. What factor is the most important for a successful clinical outcome? The physiotherapy protocol, a cemented stem, a graded tuberosity healing, or the surgeon expertise? So I give you 10 seconds to answer. Okay, and the answer, of course, is the graded tuberosity healing. Okay, Pascal, you are okay now?
I hope so.
Okay.
Uh,
So Professor Pascal will talk about the intramedullary nailing and proximal humeral fractures.
okay, did you put my talk? Can I advance or you advance, Marie?
I think I advance and you talk.
Sorry?
You can talk and I run the slides.
Okay,
Is it
go.
okay for you?
Next, please. Yeah, I have no choice. I mean, next slide, please. Next. Okay, this is what I would like to share with you in the next minute. It's what is new with IM nailing. Attendez, vous allez trop vite là. J'ai pas le contrôle. I don't have the control, sorry. Vous pouvez revenir en arrière, s'il vous plaît? Non, là, il y a toutes les diapos qui passent d'un coup. Non, non, stop, stop. Putain, c'est pas possible. Can you see my screen?
Yes.
Marie, can you follow me? When I say next, you pass the slide, please.
Yes, yes.
Okay, so what's new in inframedullary nailing for proximal humorous? There are 3 generations of nail, and this is what I would like to show you. Next, please.
Okay. Next slide.
Next slide, please. So, okay, the first generation. Non, attendez, une à la fois, parce que sinon on va pas y arriver. So the first generation of nail were too long, too big, and there was no locking technology. The second generation was even worse. They were banded nail, and because of that, they were displacing the fracture, or more importantly, they were destroying the supraspinatus tendon, because the recommendation was to enter to the supraspinatus tendon, which is completely crazy, as you can imagine. Next, please. So I designed a nail about 13 years ago. Next slide, please. Bon, ça marche pas.
I'm sorry, it doesn't run very well.
Okay, so I have no possibility to. Okay, I will. So this nail is based on my anatomical study. As you see, we have shown with Gilles Valge that the human head can be replaced with a sphere, and the medullary canal proximally can be have an axis, and this axis, as you can see, arrive at the top of the cartilage, not in the footprint of the supraspinatus. Next, please. So the nail should be entering the cartilage and the muscular part of the supraspinatus to enter inside the medullary canal. As you can see here, this is how we introduce the nail. It's a short nail, it's a small nail in diameter. Next, please. And what we want to do with this nail is not to fix the humeral head. The problem is that there is a misconception which is to fix the humeral head in fracture of the proximal humerus. You see that this nail is not bigger than a cannula. Next, please. And there is no risk to introduce this kind of nail inside the muscular fibers of the supraspinatus. But the key point is here. This nail is based on tuberosity fixation, not on humeral head fixation, which means there are 2 screws coming from posterior, 1 screw to fix the greater tuberosity, 1 screw coming from anterior to fix the lesser tuberosity, and 1 screw for the calcar if needed. And the other point is that you don't need long screw to catch the bone. All you want to do is to catch the nail, because there is a polyethylene bushing at the proximal part of the nail, and that's, if you fix the nail with a screw, that's what you need, nothing else. Suivante, s'il vous plaît. Next. And this nail, which is called the Equalis nail that I designed, I think 13 years ago, I mean, is different from the plate. As you can see, the plate is designed to fix the head. That's why you go lateral and you go medial with a screw to fix the head. And of course, this is not as good as a nail on a biomechanical standpoint. Suivante, s'il vous plaît. Next. So the nail for us is the key point, and in a young patient like this case here, 18-year-old young women, you have different options, of course. Suivante, s'il vous plaît. But I think there is no reason, absolutely no reason, suivante, s'il vous plaît, next, to use a plate in this kind of fracture. You see the displacement? Il faut cliquer sur la vidéo si on veut que ça avance. Bon, ça marche pas. Passez à la suivante. So the key point is to enter the humerus and to make derotation of the diaphysis, and then impaction, retrograde impaction, and then alignment of the fragment, and then you can fix it. Suivante, s'il vous plaît, next. So this is the example here with an animation. Vous pouvez cliquer sur la vidéo, s'il vous plaît. En bas, il y a... C'est un désastre, ce truc. Okay, you have a two-part surgical neck fracture. You just enter inside the humeral head after tilting the varus displacement. You put a K-wire inside the epiphysis and the diaphysis, and it's finished. You ream, and then you introduce the nail inside the medullary canal and the head. You go a little lower than needed. You go distally first. You put two distal screws, which are divergent 20 degrees. Then you do retrograde impaction, and then you put two proximal screws, not in the bone, in the nail. They are locked in the nail, and that's enough. Suivante, s'il vous plaît. So here is the case of this young lady that we operate percutaneously. Suivante, s'il vous plaît, il faut cliquer à côté de la vidéo, sinon ça va redémarrer la vidéo. Suivante. See the retrograde hammering, how it works. So this is an example here with this young lady. You enter the humeral head. I'm sorry for the quality of the video because of this. Then you put the K-wire inside the epiphysis and in the diaphysis. You ream. You don't open. Everything is done percutaneously through the anterior portal in front of the AC joint or posterior to the AC joint, which is the novisor portal. You see the reduction is automatic for the varus or the valgus because you enter the head. And then you align the jig, the instrumentation, with the forearm. You go distal, you put two screws, the divergent here, and then when it's done, what you do is you do retrograde hammering, and then you put the proximal screws. Suivante, s'il vous plaît. La vidéo, voilà. Donc here you see this young lady with a very displaced fracture. There is no scar. It's like arthroscopy. It's minimal invasive surgery. It's percutaneous surgery, and it works for young ladies, but of course, but also for elderly patients. Suivante, s'il vous plaît. Diapo suivante. Here is a very old lady, 91-year-old, but a very displaced fracture. This is the mother of our radiologist doctor. He asked me what to do. I say I would do a percutaneous IM nailing, and this is what I did. Suivante, s'il vous plaît. Here is this lady with the percutaneous nailing. She's 1 week after the surgery. Cliquez sur la vidéo. You see that the elderly patients push on their upper limbs to stand up. Diapo suivante. And here she is 1 month after surgery. Again, you can see that these patients, they all use their upper limb to stand up from a bed or from a chair or from an armchair. And the beauty of the nail is that this allows you this to be done at 1 week or 1 month, as in this case. Suivante, s'il vous plaît. Je crois qu'on va arrêter rapidement parce que là, c'est un peu compliqué. So this is a displacement of the different surgical neck fractures that you can have. And you can see that it's translation of the diaphysis, varus of the head or valgus of the head. But these are, you choose the entry portal, suivante, s'il vous plaît. Based on the displacement, you go more medial, which means posterior to the AC joint through the novisor portal if it's a varus displacement. And you can go anterior if it's a valgus displacement. Suivante, s'il vous plaît. Here an example, the entry point here with the novisor portal posterior to the AC joint. Suivante. Here we go. You see, you should enter the cartilage. Of course, you should never enter the footprint. Suivante, s'il vous plaît. Here an example of a two-part fracture. Suivante, s'il vous plaît. You have automatized correction. Okay, I'm not going to go too far now. I just want to explain to you why I don't plate these 3 and 4-part fractures. Suivante. 3 and 4-part fracture is very simple to understand. I mean, what you should understand is that the most important fragment to be reduced and fixed is not the humeral head, it's not the diaphysis, it's not the lesser tuberosity, it's the greater tuberosity. Suivante, s'il vous plaît. And why that? You should stop considering 3 and 4 part fracture as a puzzle that you should reconstruct. You should consider the 3 and 4 part fracture as a cuff tear. And as you can see, there are 3 tendon and muscle which are pulling on the greater tuberosity fragment, the supraspinatus, the infraspinatus, and the teres minor. Suivante, s'il vous plaît. So, if you understand that, you understand that the displacement of the greater tuberosity is the most important because it's a massive posterior-superior cuff tear. Suivante, s'il vous plaît. Next. You see the displacement here? So when you put a plate, this is what you do. You fix the humeral head. But who cares about the humeral head? Who cares? We know, suivante, we know how to replace the humeral head perfectly. We know how to fix the humeral, if there is a necrosis, we know how to do a hemi or a reverse prosthesis, but we don't know how to repair the cuff when it's fixed posteriorly. It's finished. Suivante, s'il vous plaît. So what you should understand is that this is a mistake, that the first goal that you are looking for is to restore the inclination, the retroversion of the head fragment, etc., blah, 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 etc. We don't care about that. The head, if you close the 2 tuberosity, will be fixed in the right position. Suivante, s'il vous plaît. And here we go. Suivante, s'il vous plaît. The plate fixes the head. Suivante, s'il vous plaît. But doesn't fix the greater tuberosity fragment. You see, you are putting your plate with the screws in the fracture line, which is posterior to the groove or parallel to the fracture line. Suivante. And because of that, you miss the point because you're trying to fix the head while the most important fragment to fix is the greater tuberosity. Suivante. Allez-y, avancez s'il vous plaît. Je crois qu'on va arrêter rapidement parce que c'est... And not only that, non, là ça a été trop vite, dommage. So you see that even a nail is not good if it is designed to fix the head. What you should have is to have an implant that fixes the greater tuberosity. And the plate did not help at all. It makes things wrong and worse because it destroyed the glenoid. So this is what will happen with the plating now. Suivante, s'il vous plaît. So you see that with the 3rd generation of nail, the screws are locked in the proximal part of the nail, and there are 2 screws designed to fix the greater tuberosity and 1 screw designed to fix the lesser tuberosity. So this locking technology allows you to repair the cuff, in fact, and the head doesn't need any fixation. Suivante, s'il vous plaît. So we do this through a superior transacromial approach with an osteotomy of the tip of the acromion. Suivante, s'il vous plaît. And this is what we do here with the nail. So in this case, with a very severe displacement of the greater tuberosity, which means a massive cuff tear. Suivante. What we need to fix is the greater tuberosity fragment and to reduce it. Next. 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 Okay, this is the short video to show the surgery. You do a saber cut approach for the skin because it's more aesthetic. And then you do a transversal incision and you detach the anterior deltoid by making an osteotomy of the tip of the acromion. You take about 5 millimeters of bone. You lift up the head. You introduce the nail in the humeral head fragment after removing the biceps tendon, of course. You do a tenodesis of the biceps tendon. You put suture here on each side. And what you do is that you put the nail through the humeral head in the medullary canal. Once again, you're going to make automatic reduction of the displacement of the head fragment. And then when this is done, you can close the book. You can reapproximate the 2 tuberosities together. So you introduce the nail because it's cannulated on the K-wire. You align the instrumentation on the forearm because you need to arrive from posterior to fix the greater tuberosity. You go distal first, then you go proximal, and you fix the tuberosities posteriorly and anteriorly. So this is very different. You don't care about the humeral head fragment. It can goes nowhere. I mean, the head fragment will stay there. When you will reduce the two tuberosities together, there is no displacement possible of the head fragment because it is trapped inside the joint. You take a clamp, you close the two tuberosities together, and then you fix the tuberosity posteriorly, the lesser tuberosity. Again, you don't need to pass to catch the bone of the humeral head. All you need to catch is the polyethylene bushing of the proximal part of the nail. That's it here. And then when this is finished, you can move the shoulder. You see that there is no screw inserted in the head, but because you don't need anyone. Then you close the defect in the muscular part of the cuff. You see the screws in the front, the screws in the back. The cuff is repaired, the job is done. All you have to do is to reattach the tip of the acromion, and that's finished. That's a reconstruction of the proximal humerus. Suivante, s'il vous plaît. And reattachment of the deltoid here without any problem. Appuyez pour la diapo suivante, s'il vous plaît. À côté de la vidéo, okay. This is an example here. You see the fragments which are reattached. Suivante, s'il vous plaît. This is the lady here. Allez-y, levez les bras. Cliquez sur la vidéo, s'il vous plaît. Suivante, s'il vous plaît. Next. This is another example here. You can have a very displaced fracture and you can see that you can fix everything. So these are the take-home message. I mean, there is no reason for me to plate anymore. Next. There is no need to open a two-part surgical fracture. No need to plate it. I mean, I think today there are a third generation of nail which is available, which is completely different, which is small, with locking technology and tuberosity-based fixation. Next. This is why we should at least accept that this exists. And this is the last slide I would like to show you. There are 3 reasons to operate a 4-part fracture. Suivante. The supraspinatus, the infraspinatus, and the teres minor, which means, again, the most important fragment to repair is not the humeral head. It's the greater tuberosity fragment. And you cannot do this with a plate. You can do with sutures. You can do with a nail like the one that I present to you, but you cannot do the nail because with the nail, what you do is just to fix the humeral head. I will stop here. Thank you very much.
So thank you very much, Pascal. Excellent presentation. So we have some questions from the audience that have been answered from the participants, most of them. I just want to, because we are a little bit late, for everyone to, to have a conclusion, a point about their presentation. Start from Zenon. So what are the boundaries?
Have we discussed, is there any question that should discuss, first of all? Because I would like to ask, let's say, Pascal, something.
Yes.
Okay, yes. Pascal, thank you for the excellent presentation since you are the last presenter. May I ask you something? What is for the average trauma or shoulder surgeon, what is the average learning curve to do intermediate nailing to treat these fractures? Because most surgeons do not do nailing for these types of fractures, including me.
I know, and thank you for asking me because this is a very important question. I think you should, if you want to try this kind of IM nail, you should start with a 2-part surgical neck fracture because this is the easier to manage. So you should enter, I recommend to enter now systematically, almost systematically through the no-visor portal, which means posterior to AC joint, and to enter really the humeral head fragment, about 2 to 3 millimeter from the footprint medially. And you have an hole, specific hole that you can enter in the humeral head. This hole is cannulated. You can introduce the K-wire, which is guiding you, and you guide this K-wire inside the diaphysis. And when this is done, you just have to rim a little for the entry of the nail, and you put your nail and you go distal, a little 1 centimeter lower than needed at the top. You fix distally, and then you do retrograde hammering after correction of the rotation of the diaphysis, and you fix the proximal fragment. It's really not difficult to learn to do a 2-part surgical neck fracture percutaneously. I mean, all my fellows for the last 10 years do this in 10-15 minutes. It's unbelievable how easy they are. They have learned this procedure. And if people want to start with a nail, I would recommend to start with a 2-part surgical neck fracture percutaneously. For the 3 and 4 part, it's more complex, of course, because you need to open. I recommend to do a surgical direct transacromial approach like the one I show you. But it's not so difficult either. Sometimes you have to bone graft, and you can bone graft around the nail. But again, the goal is to repair the two tuberosity together, and then in fact, it's like making a cuff repair. So I can tell you, frankly, I'd never put a screw in the humeral head since 20 years. I've been using this kind of nail for almost 20 years now, and I didn't put one screw in the humeral head fragment in 3 and 4 part fracture, and I promise you, it's true. I never had to reoperate any patient for displacement of the humeral head. And again, as I said, we know how to replace the head fragment if it necroses. We do a hemi or a reverse, whatever. But we don't know how to repair the cuff when it's completely retracted posteriorly with fibrous tissue, a very small greater tuberosity fragment. It's finished. As you know, there is no way we can solve this situation. So my point is that we should stop using the plate because the plates do harm. This makes things worse than before. Because if you have a 30 or 40 years patient with a necrosis of the head, posterior migration of the greater tuberosity, and destruction of the glenoid because of the locking screws of the plate, it's finished. You have to do a reverse prosthesis for these young patients. And unfortunately, you have to tell this patient that it will be a reverse prosthesis with a poor result because of the absence of posterior cuff. So I think that when something does harm in orthopedic surgery, we should abandon it. And I'm sorry for the people who are here and who are convinced that the Philos plate is the best thing in the world. For me, this is the worst thing in the world.
If you want to remove the nail, it's easy for an infection, for example.
If you have to remove a nail, it means you have if you have to remove the nail, it means you have to do a prosthesis. You do a deltopectoral approach, and since you open the joint and you remove the nail very easily. And since the nail is not very long, you can remove the distal screw through your deltopectoral approach. So this is really easy.
Okay. Any other question, Ines? Any comment about the Philos plate?
I mean, the nail, I think it's really important to emphasize that you need to make beforehand reposition, and then you need to introduce the nail, because sometimes what I see that some people try to do the reposition with the nail, and then it can lead to big trouble.
But what we must say is that the design of the nail matters. I'm sorry because I have a conflict of interest here because I designed the nail, but all the other nails are not designed for fixing the tuberosities. They are designed to fix the humeral head exactly like the plate, so they are not good. And even when they can be even worse than the plates because they are banded, they are curved, and this is even worse. So I think that we should really realize that there are 3 generations of nails. First generation were very bad. They were straight but no locking technology. Second generation were even worse because they were curved and they were entering the cuff tendons. And there is I think that the one that I designed for the moment is the only 3rd generation nail. I've never seen on the market any nail which is designed to fix the tuberosity with locking technology.
There is a question from the audience for you, Pascal, and It is unanswered. What is your opinion on treating a 3-4-part humeral fracture with an intermediate nail? It is possible to keep the medial calcar stable and prevent secondary displacement, or locking plating is far better doing it?
Yeah, it's very possible because there is a 4-screw which is available proximally to maintain the calcar at the right position. And of course, it's a very displaced fracture, and you have a impaction of the cancelled bone. You should allograft to bone graft, but it's really possible to treat a very displaced 4-part fracture with a nail. And again, if the humeral head fragment get necrosed, this is not a problem. The locking screws through this nail, since they are fixing the tuberosities, will not destroy the glenoid. So you have just to remove the nail and the screws and to replace the humeral head, and you're done.
Okay, there's another question. What is the complication of this third generation nail, if there are any complications?
In 2-part surgical neck fractures, there is almost no complications, except if you put the nail too high and you leave the nail rubbing against the cuff muscles, but you should pay attention to this with fluoroscopy. In 4-part fracture, in 3 and 4-part fracture, the main risk is a necrosis of the humeral head. But again, as I said, if the head necroses, you can still solve the situation. You did not burn any bridge. You can do a reverse with good results, or hemi if it's a younger patient. You don't burn any bridge because you don't destroy the glenoid, in addition to missing the point, missing the target, because you are fixing the head but not fixing the greater tuberosity. I think that if we stop seeing these fractures as a puzzle, as the AO is emphasizing, the AO is right. I love the AO. I love the AO for the tibial fracture, the femoral fracture, the ankle fracture, all the fracture in the body, except in the shoulder. The shoulder, the fracture is not a puzzle. In the shoulder, the fracture is a cuff tear. If you understand that in the shoulder, the fracture is a cuff tear, you understand that what you should do is a cuff repair. And I can tell you that it's a massive posterior superior cuff tear. And when we were doing open cuff repair, we would never do this through a deltopectoral approach. We would do this through a superior approach. And Andreas, maybe you remember that. But open cuff repair did exist. We knew how to do a superior approach. Today, nobody knows how to do a superior approach. So of course, if you want to do everything through the anterior approach, it cannot work. Because how can you, from an anterior approach, fixing a posterior problem? A massive posterior superior cuff tear with migration of the greater tuberosity? You cannot. So you are coming from the front, you're putting the arm in abduction, internal rotation, and the greater tuberosity fragment stays in the back. So what do? You put your arm in external rotation, but then you cannot put your plate. So you put again internal rotation, and the bone fragment stays in the back. It's finished. 1 centimeter displacement of the greater tuberosity means massive posterior superior cuff tear. So my recommendation for 3 and 4-part fracture is do a superior approach, use a 3rd generation nail that fix the tuberosities and not the head, and make a nice cuff repair, and it's done. Whatever the number of fragments, you don't care. All you want is to repair the cuff.
Okay. Any other question or comment?
I ask Ines, do you use any augmentation such as bone grafts or fibular graft in displaced or osteoporotic bone when you do open induction and dental fixation?
So sometimes, yes, we use something, but unfortunately, it's a little bit problematic in Latvia with the bone bank. So we don't have the fibular strut grafts. So it's a problem for us. So sometimes we use the femoral heads, and yeah, that's what we use. But usually, I think it's still enough if you restore the medial hinge, and then you can maintain the stability of the fracture. And I mean, I agree with Pascal that sometimes the nail can be a good option. Unfortunately, we don't have, Pascal, your company nails. We have the bad ones which fix the head. But sometimes it's really benefits because it's intramedullary fixation, and actually it avoids from the varus displacement of the head, especially also for these fractures when there is medial comminution.
Just
Okay.
ask for it. You will.
No, I think we can finish it was an excellent webinar. Thank you all for your participation. At some point, we had more than 200 participants, as you can see here. So I think everybody is happy, and we learned a lot of things from this very good talkers. So now we can go. Thank you very much. Thanks, Kek, and we can have the promotion of the slides for the next webinar from Christian Gerber. So it's a scapular corrective osteotomy for the posterior escape, and it's 16th of February 2006. And also we have, don't forget to join the SEKE community. And it's a free junior membership for doctors less than 32 years old. Of course, we have the SEKE Congress in Barcelona the beginning of September 2026. So thank you very much, everyone. It was an excellent webinar. So have a good night.
Good night to all. Thank you very much.
Okay.
Have a good night.
Thank you very much, and sorry for the problems.
We solve it. Okay.
Yeah.
Bye-bye.
Good night to all. Bye.
Bye.